All right. Welcome for another episode of G&T, Ghanem and Teixeira, of our webcast. We thought today we would talk about a little bit more about differences in duodenal switches of traditional and SADIs, right? SADIs mean the single anastomosis or the loop switches or the SIPs. So different names out there, they all mean the same. Versus a traditional, which is a different way to do it that has one connection, two connections, right? The loop only has one connection. I think there is a lot of misinformation out there in terms of the difference. I think it would be good for us to kind of debunk some of them. And I think we should call it the myths of duodenal switches, traditional versus loop, and go from there. So I'll start with one. Myth number one, Ghanem. So people believe that the single anastomosis switch or the loop switch is an experimental procedure. What do you know about that?
So it is not at this point, actually. So it's fairly established procedure and has been around for quite a while, talking now at least in 2022. And as a matter of fact, it has been endorsed as a procedure by the governing bodies of the bariatric and metabolic surgery in the United States. So it is not an experimental procedure. It's an endorsed procedure by what we call the ASMBS, which is, again, one of those bigger kind of government bodies on bariatric surgery. And what other people also might say that this is not the real duodenal switch. It is still a duodenal switch. It's a different variation of the duodenal switch, but it's still very much a real duodenal switch.
Yeah, it's like I like to use the example, right? The gastric bypass, the ruler wide gastric bypass, and the mini gastric bypass. So the one anastomosis gastric bypass, right? It's just different variations of it, right? It does not mean that you're going to get better or worse results or you're going to lose more weight versus one versus the other. So, which is interesting. People have to understand that there are variations from different procedures like sleeves, right? It does not mean that every single surgeon in America does a sleeve with the same size of the bougie of the tube that we use. Mm-hmm. It varies between 32 to 40 French, right? In reality, there is really no difference in weight loss. The difference is the tighter you go, higher complication rate you can have. So that's what people have to understand. Okay, so myth number two. Loop DS or SADIs DS or one anastomosis DS, you lose less weight compared to traditional.
Mm-hmm. And that is all. Sorry, go ahead. Yeah.
No, go ahead.
And that is also has been proven to be not true. Of course, each procedure is suitable for a different patient population. So we have to, I always tell the patients, it's not a best procedure and a worst procedure. They always ask us this, right? They tell which is the best procedure for you, in your opinion. There's no such thing. It's like a lock. You have a key. A key only opens one lock. That doesn't make it the best key. It's suitable for that lock. Same thing with these procedures. They're suitable for different patient populations with a context, which we will talk about in a bit. But if you are a same patient for most patients who have not had any previous surgery in the past, then the weight loss has been shown to be fairly similar with both procedures.
Yeah, so same thing. We looked at it at the same time that we're looking at our own results. Spain, some groups in Spain were looking at their same results, right? We presented at the same time. We know each other, the groups, we know each other, but we didn't know we look at the same things. And doing the presentation in 2017, I think, or 18, of SMBS, the results on the screen, one after another, were the same comparison between a single anastomosis or loop anastomosis versus traditional. There was no difference in weight loss between the two procedures. Okay, so You have to be careful when you start listening or believing on things they're said on social media, or on Dr. Google, Dr. Facebook, or Dr. whatever, right? You have to have scientific knowledge or background to be able to support what you're stating, right? And the truth is, I actually was a super believer that at one point, at a BMI, a super high BMI wouldn't make a difference until I proved myself wrong with data, right? We collected our own data combined with Spain data, which why Spain? Because they do a lot of single anastomosis switches there too. And we saw that there was no difference. It doesn't matter which BMI you have it. Because you have a high BMI, you should have a traditional. That's not true either, right? So, but I want to stop here for a minute because Ghana, your comparison between a lock and a key, very interesting. Is there some kind of Valentine Day in Israel, or did you go to Tiffany lately to buy something for your future wife?
No, it's the lock and the keys to the doors behind me. That's where this analogy comes in. You have to compare
you tie
to
back
that.
Old episodes. I like it.
Exactly. There you go. It's like this. We make them like this. We make them watch the previous episodes too.
So those are right there. Couple things. The third thing is, people believe that you're going to have more side effects with a traditional versus a single anastomosis. Is that true or what?
So that is also not necessarily true.
Correct.
So again, different variations of the same procedure. And so you will still have, if you are somebody who suffers from severe reflux from the get-go, then also this might potentially aggravate it. Again, talking about different patients and different circumstances, this may vary. And the side effects will also, you still have potentially the same side effects of diarrhea and malabsorption with the SADI, albeit that there seems to be less of that in certain populations. A lot of patients also have that myth, which with the SADI, you don't need to take the same vitamins as you do with the duodenal switch, but that is also not true. Because with the SADI, you still have a duodenal switch and you still need to take the exact same vitamins as well.
You're correct, man. A SADI, the way we treat switches, doesn't matter what switch you have, we treat them very similar. There's no difference in the nutrition perspective, the nutrition evaluation, the teaching after surgery, no difference in what vitamins they're going to take, and also no difference in how you're going to check your vitamin levels throughout the year, right? So because you have a variation of one procedure, the care should be the same, right? Because it makes the life easier for the patient. It doesn't matter which one you have, right? Granted, it is pretty well documented that patients that have a loop switch or single anastomosis switch have much lower chance of having issues with vitamin deficiency compared to a traditional, which makes sense because you do have a bit longer for absorption component, right? Mm-hmm. But in terms of the dietary component, the response to high fatty, greasy foods, high fried foods, the response is the same, right? So, which is interesting because you have the benefit of a traditional to make you stay away from it without the issues of the vitamin deficiency if you don't take your vitamins. Make sense? Mm-hmm. So, it's kind of have the best of both worlds into one procedure, right? But anyway, so are we advocating that one is better than another? By all means, no, right? The beauty of bariatric surgery, which is hard to come by, is you, as a surgeon, try to match the best operation to the patient. But the best operation to the patient long term, right? A 2-year, 3-year weight loss to me doesn't mean much, right? 5, 10, 15 years. That's what I'm talking about. That's what our goal, our practice is, right? So that's important. People understand that when we're talking about one versus the other, right?
Right. So is there a specific area or patient population in which the traditional duodenal switch shines and does better than the SADI? Because we talked about certain things where it's the other way around. So which patients would you tend to push towards the traditional duodenal switch as opposed to the SADI?
That's a good question, man. So unfortunately here in Florida, we are kind of sort of, I would say, landlocked, right? Because we can't really take the patient and operate on them and say, I'm going to do a single anastomosis switch on you and go through insurance, because insurance is not going to approve, right? So I can't really do that. So insurance tells me you can only do a traditional, right? So majority of our single anastomosis switch that we do are patients that are self-pay. Granted, there are specific patients that come to us that if they have liver issues that are found in the operating room, right, very high content of changes of fat of the liver structure, or we call the NASH, right, non-alcoholic steatosis hepatitis, right, or the liver is not normal anymore, then we tend, and those patients are high BMI, greater than 50, right, diabetics, high cholesterol, high triglycerides, that true metabolic patient, then we do a SADIs on those patients. But we discuss with the family before we do, or we go and talk to them, because that is the only option those patients have. A sleeve alone for those patients is not going to do anything. So that's how I do it, How about you?
Right. What about patients that have had, say, a sleeve in the past? They came in for a revisional surgery for weight regain after a sleeve and are looking into the duodenal switch.
So, it's a good question, because there's not a whole lot of data comparing revisional sleeve to single versus traditional, right? I know in our practice we have more than 2 surgeons. One of them believe they should convert them all over to traditional, right? Well, when I look at my numbers, when I look at my patients, I don't see difference on them, right? So if the patients come to me and they're self-pay, I'll let them choose what they want, right? Unless if the patient is a super high carb sugar eater, right? Then I tend to push them more to a traditional, right? Because the biggest thing about most of the patients I've seen that have regained weight on a switch, which it's not that many, are all sugar carb eaters, especially a lot of carbs, right? So that's one way I try to help out.
Right. Also, some patients that when we go in as well, and during the procedure, we find that they have severe scar tissue, or we call in medical terms adhesions. If we're able to free up enough to do one anastomosis, but we don't want to take, that goes well, everything goes good. We don't want to increase the risk of the procedure, so we might end it there and do the single anastomosis instead of doing the traditional, but that can be an intraoperative decision, just like Dr. T said, with patients who have severe liver disease, NASH or NAFLD as well, during the, or found to have that during the surgery.
So I agree. I agree with you. The other category of patients that I tend to do a traditional versus a loop, right? More so, depending, that decision decided in are conversions of bypass to DSs, right? And that decision sometimes depends on how long the patient been operating room, how difficult was the rebuilding of the stomach and so forth. So those decisions, right? But making things a little bit easier for our listeners is lifestyle, right? Is there a difference in their lifestyle compared to it?
Between the two procedures?
Yes.
Yeah. So technically not. In terms of eating the foods that they need to stay away from, the way that they need to exercise, there is no change in that. There is some data that shows that there can be less diarrhea or less loose bowel movements with the single anastomosis duodenal switch. And like you've stated beforehand, less also vitamin deficiencies as well. But in terms of what the patient needs to do, it needs to be exactly the same.
Total agreement. So the other question is, which is very interesting on switches, right? And which is interesting. Most of the time people should ask those questions to us before surgery. But they always ask after surgery, when it's already done, is what is the size of my common channel, right? So common channel is a distance between the end of your intestine to where the connection is between the intestine for a traditional DS, right? So I guess there are some sites that talk about you should ask for the lowest possible common channel, right? What people don't understand is when Duodenal Switch came out, it was the original operation way back in the 70s, right? The common channel was 50 centimeters, right? The reason why Duodenal Switch went away was because that 50 centimeters put a lot of patients in liver failure, right? So people couldn't survive, they didn't do well, malnutrition, it went away. So then they elongated to 75 centimeters, right? Still didn't make a difference, and then disappeared, right? Switches came back again recently, if you think about it, right? We've been doing since 2014, right? So, and there is a reason why it came out, because it started back up with the SADIs, right? With the loop. So people start with 200, 250, 300. So majority of people do about 250 to 300 between, right? So, and then the common channel ended up being 125 to 150, right? So shorter than that, you are asking yourself a lot of problems within 2 years that you're going to have reversed it or converted to a bypass or converted to something else because of severe malnutrition. That's why I tell patients, you have to be careful what you wish for, right? What do you think?
Yeah, absolutely. And it is very important to touch on that point, that patients think, or even some doctors, I would say, think that the duodenal switch is a novel procedure. No, it is not. It's old. It went away because of those very short common channels causing severe issues in patients. Now, luckily, nowadays, we figured out what the length that can be that would give you enough weight loss, but not too much as well that you are having severe diarrhea, severe protein malnutrition, and potentially liver cirrhosis as well. But it's important to remember that it's just gaining popularity because we're having better results with that. One of the reasons that it's gaining more and more popularity now, it's because we're seeing patients with higher and higher BMIs, in which case, like Dr. T touched at the start of the episode, with BMIs of 60 and 55 and so on and so forth, sleeves won't usually do. They would help, yes, for sure, but they would not do. And it's important to say that also the duodenal switch actually gave birth to the sleeve as the procedure that is now the most commonly performed bariatric procedure as a first stage. And back then it was done in a staged fashion. Things were a little bit different then, just like we talked about. So they would do the sleeve, wait for patients to lose a little bit of weight, and then do it in a staged fashion. Now we sometimes do it in specific patients, but rarely so.
Yeah. The other thing it's important to understand is when we talk to patients in regards to having switches, one of the questions I ask them, and I don't care what kind of job they do, how much money they're making, is can you afford the vitamins? Because you can have the best weight loss you can in a procedure, but if you don't take the vitamins, which is required, right, for the switch, you can have pretty bad complications from it, right? One being night blindness because of low vitamin A. bleeding issues because of the vitamin K, right? Calcium, vitamin E, I mean, you name it, right?
Mm-hmm.
So you have to take the vitamins. It's very important. So we really emphasize this on the patient. That's why we see those patients after 6 months of surgery, every 6 months, to make sure that there are no issues with the vitamins, right? So
right, and if that's something that you feel is not suitable for your personality, that you don't think you can take the vitamins consistently, then I would suggest highly that you look into the sleeve instead. Have the sleeve, which even then you have to take vitamins, but they're much less so than the duodenal switch, and have less weight loss as a result. But I'd rather take that rather than have you have the duodenal switch, not take the vitamins, and have complications. I always say, and we both always say, we don't want just patients, we want successful patients too. Right?
Totally agree with you, man. I couldn't argue with you more. Our goal is to have successful patients long term, right?
Mm-hmm.
Without issues. And I tell patients that I love to see them back in the office, but just for follow-ups, right?
Exactly.
I don't want them to see for issues because of they're not taking vitamins and not following instructions and all that, because, that's why we tell them it's important for them to understand that. Like we always said, the easiest thing of the whole journey is the operation. What comes afterwards is the hard part, right?
Right, exactly. And that's why we always say that the patients still have to do the harder part of all of this, because for us, really, it's a few hours. Might be a little bit challenging, those few hours, depending on the case, but usually it's easy and then we're done. But then you're the one who has to fight the temptations, put in all the work every day, every year, so on and so forth.
Yeah. But remember, our office is always available to help everyone. Doesn't matter if you have DS somewhere else. We're still here to help anyone that have questions on nutrition, or team, everybody. Anyway, great episode today. It was awesome. I think it's always important for us to talk about different topics. If you guys have any topics that would like us to discuss, by all means, tell us what we want us to discuss, and we will discuss. So if you want us to invite anyone, we will. Good to see you, Ghanem.
Great to see you. Have a good night.
Good night.